Hello, I'm Darcy Taggart. I am a licensed art therapist and a licensed clinical counselor here in the state of Kentucky, as well as a registered play therapist. And I am here today as part of the Aetna training series to talk about autism diagnosis and co-occurring disorders. I also run a private practice here in Louisville called Creating Connection, PLLC. We are a play and expressive-based practice for children, adolescents, and families, as well as some adults, and provide primarily expressive and play-based interventions. It is through this role that I'm coming today to talk to you about autism spectrum and co-occurring diagnoses. And I'm hopeful that in the next 45 minutes or so, I can give a brief overview of several of the different disorders that sometimes occur along with autism spectrum. My objectives for today, or my hopes by the end of this time, is that you will be able to identify the basic diagnostic criteria for the diagnosis of autism, that you will learn some of the medical co-occurring diagnoses that tend to affect individuals on the autism spectrum, and that you will learn the most common co-occurring mental health diagnoses as well. So what is autism? Autism is a lifelong developmental disability. It results from a neurological disorder that affects the brain and its functioning. It is not poor parenting. It is not bad behavior. It is not a lack of desire for social engagement. It is something that occurs long-term with individuals, and individuals with autism have neurodiverse brains, and they are often affected in different areas, but no two areas or no two people with autism are exactly alike. As you'll see on this slide, while we think about autism as being a spectrum, and often people think of that spectrum as being linear, with there being one end of autism over here and one end of autism over here, what the truth is that someone with a neurodiverse brain can often be different in different areas. So they might have high perception skills, but poor language communication skills, or high or low sensory needs, or difficulties or differences in executive functioning skills. And so really, the autism spectrum is a little bit more like this rainbow wheel that you see on this screen, where each individual is different in the level of difficulties or strengths that they portray in different areas. Some prevalence, some general demographics of autism spectrum. From 2020, the estimated prevalence in the United States was 1 in 36 children were diagnosed with autism spectrum. The estimated rate of 2 to 3% of all adults, it comes from that same data in 2020. It occurs across all racial groups, ethnic groups, socioeconomic groups. It is 4 times more common in boys than in girls, and there's no one cause of autism, even though we do agree, or lots of experts agree, that there may be a genetic component in some versions of autism. There are some diagnostic categories for the diagnosis of autism in the DSM. Several years ago, when they updated the DSM from the DSM-4 to the DSM-5, they shifted the diagnostic criteria. Prior to the DSM-5, we had 3 domains. We had social impairment, language and communication impairment, and repetitive, restrictive, stereotyped behaviors. At least 6 out of the 12 deficits needed to be met in these 3 domain areas in order for an individual to get a diagnosis of autism. When the DSM-5 came out, we had 2 domains. They shifted the way that the diagnostic criteria was created. So they lumped the social and communication impairment in together, dropped the language component, and then had the restrictive and repetitive patterns of behavior. In order to now meet a diagnosis of autism, individuals need to have deficits in all 3 areas of social communication and at least 2 symptoms of restrictive or repetitive patterns of behavior. The new symptom that was added when the DSM-5 came out is that there was hyper or hyporeactivity to sensory input. We are going to talk a little bit about sensory processing through this presentation. But for sure, when we look at deficits in social communication, at least each of the areas needs to be met, that the way that the individual is using communication is affecting social engagement. We have sort of the triad of autism impairment. And this is the triad that we use a lot of times for that. We look at the communication, the social interactions, and the activities and interests. But many individuals with autism are skilled in a non-social domain, maybe building or music. But this is just an additional sort of diagnostic triangle for you to be able to look at the triad of impairments in ASD. Many individuals on the autism spectrum, however, do not feel like our deficit model of current DSM criteria really fully identifies all the things that are going on with that. All of the criteria in the DSM is related to deficits, but individuals with autism may also have unique strengths, and they may be skilled in a non-social domain. As I mentioned, people with autism can have a range of strengths, including attention to detail. They may be precise and very detail-oriented. They may have high visual perception skills and a heightened sense of color or understanding of visual dynamics. They may think logically or think and learn visually, and they may be good at identifying irregularities in different categories. They may have excellent memory skills, and some of them have what is described as like a photographic memory. They often are very honest and can be unfiltered in the way that they tell individuals things. They'll tell you what they see without judgment or without specific belief about what they're saying. They're just honest in their perception of the world. And they can develop really deep expertise in topics that interest them. A lot of the individuals with autism have a very strong knowledge base of whatever their unique interest is. They may be very creative and have artistic talents that goes into those non-social domains, or mathematical and technical abilities, or excel in a specific area of academics. They may have a strong sense of justice or a sense of what feels right or wrong to them, and they can be very loyal. Individuals often can have a good sense of humor. So those are just some of the strengths-based things that research has shown. And also that individuals with autism want people to know about that diagnosis as well. Research suggests that strengths-based interventions can help individuals with autism improve their self-esteem and their confidence, their social and life skills. Another presentation that I know is part of the Aetna series is one on play-based interventions for individuals with autism, and those can often be strengths-based interventions for those individuals. The saying goes that if you have met one person with autism, you've met one person with autism. This goes into the strengths-based model, but also the model of looking at each individual with a neurodiverse brain is different than other individuals with a neurodiverse brain. Knowing how someone's brain works and functions can absolutely be the best thing to do for that specific individual. So I'm hoping that through the rest of the slides that we're going to look at, that you can also gain an understanding of some of the co-occurring disorders that happen with individuals on the autism spectrum. Sometimes I think when we get a diagnosis of autism, we try to chalk every experience or everything that the child or that individual is experiencing up to that autism without looking at, are there other things that might also be occurring with this individual that could help to explain, or that we could do some service provision on in order to decrease symptomology and difficulties. The first co-occurring thing I want to discuss is intellectual functioning. We used to equate autism with intellectual disability, and now we know that both of those things are on a spectrum and in a range. Those with ASD may have a lower IQ score, an average IQ score, or a gifted IQ score. There does seem to be some evidence that females with autism are more likely than males to have an intellectual disability, but this may be related to the incidence of autism being higher in males than it is in females. One of the things we know about intellectual disability is that it's a spectrum too. And the prevalence of intellectual disability in the general population of children ages 3 to 17 years old is about 1.65%, which comes from data that we know from 2021. About 10% of people with an intellectual disability also have a diagnosis of autism. And we're not sure if that rate might be higher, but that's the current rate that we have with that. Estimated rates of intellectual disability in ASD vary widely. They're influenced by intelligence tests used. Many of our intelligence tests that are used to determine IQ functioning are based on a verbal scale. And many of our individuals with autism are not as gifted in verbal language as they may be in other ways of communicating. And so when it looks at, there was a study done by the Center for Disease Control in 2018 that found that among individuals with ASD, 44% had an IQ score in the average range. So that's that average range between 85 and 115 that you see here on this IQ scores visual. 24% of them scored in the borderline range, so somewhere between a 70 IQ and an 84 IQ, and 32% had an intellectual disability. So that would be an IQ score that falls below 70%. However, what was not really looked at was what does that look like in relation to giftedness. And we know that there's some intellectual giftedness in autistic children, and that really for autistic children about 0.7 to 2% are identified as intellectually gifted. That's compared to about 1% of the general population. So it might be higher in individuals with autism. It can be hard to determine IQ, which we talked about, especially given that verbal nature of those IQ tests. It is important to note that an individual who qualifies as having autism, and also some sort of intellectual difference, so whether that is an intellectual giftedness or intellectual disability, those individuals qualify as twice exceptional students. And often twice exceptional students vary greatly in their presentation in a classroom. Individuals who are autistic and also gifted may look different than just a typical, or what we expect to be a typical individual on the autism spectrum, and than what we expect of a typical gifted student. The same goes for individuals who have autism and some sort of intellectual disability or a lower IQ, that those individuals may look different as well. So it's important to really not look at either category and expect somebody to fit into that box, but to really look at both and to help individuals identify what their unique strengths and their unique profile is in relation to intellectual functioning. The next thing we're going to look at is learning-related disorders. I put several different learning-related disorders on this slide, and we're going to talk about each of those ones and kind of what they mean. Dyspraxia is a developmental coordination disorder. This disorder affects the motor coordination and planning and includes difficulty with tasks that require gross or fine motor skills. Approximately up to 50% of individuals with autism spectrum also have some degree of dyspraxia. This may be because both conditions affect the brain's ability to process information and coordinate movements at the same time. Some common signs that you might see that these two things are overlapping might include difficulty processing information and coordinating movements, sensory processing difficulties, challenges in emotional regulation, or impacts on academic performance. Some studies find that kids with autism are often under-recognized for motor impairments and are not receiving as adequate physical therapy supports for that. When we look at the need for dyspraxia, physical therapy would be one of the reasons, or one of the things that we would do, one of the treatments for that, because it would help to improve motor coordination, either physical with fine motor or physical with motor coordination development. Another learning-related difficulty is executive functioning. Executive functioning includes difficulties with organizing, planning, time management, and task initiation. And often individuals may appear disorganized, but maybe they have really great problem-solving skills or creative thinking skills, but they struggle with organization and they struggle with task completion. Executive functioning difficulties are common in individuals with neurodevelopmental diagnoses and also therefore common in individuals with autism spectrum. We believe that it affects about 41 to 78% of individuals on the autism spectrum. One of the other things that executive functioning can sometimes affect is just individuals' ability to organize and sequence tasks. And so when we get into school-related difficulties, the idea of like a project base, that I have a project and I'm struggling to figure out what the steps are to complete that project to get it there. I may have really amazing creative thinking skills, but not know the motor planning to get there, to be able to put it out into the universe. Dyscalculia is a learning disability related to difficulties with mathematical concepts. It is approximately 3% in individuals with autism, which is actually comparable to the general population. It is said that there's a possibility that that there's a little more than that just based on that, but ultimately dyscalculia is one of the learning-related disorders that seems to be about the same for neurotypical individuals versus neurodivergent individuals. Dysgraphia is the difficulty with handwriting and fine motor skills. This definitely comes into play when our individuals go into school sittings because dysgraphia involves writing. We don't have any specific diagnostic understanding of like the prevalence of dysgraphia among individuals with autism, but it definitely, we know that it may account for slower speed and lower quality of handwriting for those individuals. Dysgraphia consequently has a high rate of correlation with things like ADHD, but maybe not, we're not entirely sure how it correlates with individuals with autism. And dyslexia is a learning disability that primarily affects reading and language processing. We know that it is higher in individuals with autism than it is in the general population, with some studies saying that up to 50% of individuals on the autism spectrum may be also affected by dyslexia. It is difficult to determine what function learning disorders, or really what function communication difficulties have in diagnosing learning-related disorders, because often individuals who struggle with adequate communication or being able to communicate their internal experiences to those outside of their environment may have difficulties saying what their struggles are with learning-related disorders. And so it's important to pay attention and not just assume that the learning-related difficulties are related just to the autism, but to continue to also look at some of these other learning disorders to see if maybe they're at play. The next thing I would like for us to talk about is disorders of processing, which includes auditory processing, sensory processing, and visual processing difficulties. Sensory processing disorder affects how people process sensory information from their environment. It can be heightened or diminished sensitivity to sensory stimuli that impacts daily living skills. Approximately 71 to 94% of individuals on the autism spectrum have some sort of sensory processing difficulty. While I have met kids with sensory processing disorder that are not on the autism spectrum, every kid I know that is on the autism spectrum has some form of sensory processing struggles. Just because an individual has some sensory processing difficulties does not mean that they meet the full criteria for a diagnosis of sensory processing disorder. It may be that they have just difficulties in one specific area. Maybe it is touch sensitivity or noise sensitivity or visual sensitivity, and those are the specific areas. But it is definitely something that oftentimes I will send individuals for an occupational therapy evaluation to determine what their sensory profile is and how to best use that sensory profile to support that individual. Auditory processing disorder makes it difficult for people to understand the sounds around them. ADHD, for example, at its core is an auditory processing disorder. The prevalence is unknown in individuals with autism, but some estimates state that maybe 93% of individuals with ASD have some sort of an atypical response to sound. Now, that atypical response to sound might be related to sensory processing. It might be related to executive functioning skills. It might be related to an actual disorder of auditory processing. Visual processing disorder is difficulty interpreting visual stimuli that we see in the environment. So maybe struggling with recognizing shapes or letters or patterns. Vision therapy can be really helpful for individuals who are affected by visual processing disorder. And one of the things that we know about vision processing is it's not necessarily inadequate vision. It often is not the difficulty to actually see things, but it's more about the way that my vision is organized and the way that I'm able to take in information visually from my environment and use it. We know that some individuals with autism have refractive errors. Between 20 and 44% have refractive errors, which is a visually significant one like hyperopia or astigmatism. About 1/3 of individuals with autism have a strabismus or an eye turn. There may be amblyopia, which is 1/5 of individuals. Amblyopia is another visual difficulty with that. Global motor processing, so individuals have difficulty processing motion, right? Processing the perceptions of multiple objects or multiple moving things that relate together. And they may have difficulty processing facial expressions or discriminating between different facial experiences or different facial eye gazes. So that's another way that visual processing may affect individuals. It could also be that they have some difficulty with eye tracking or with optic nerve abnormalities. A really good visual exam is a good thing for individuals with autism to have, and preferably with someone who specializes in working with individuals, especially if the individual with autism has limited or difficult communication preferences and needs someone to be able to help them understand how to communicate what those visual processing difficulties are. Next, we're going to move on to common medical diagnoses and take a look at Fragile X, seizures, and gastrointestinal issues. About 1 in 4 children with autism spectrum disorder have seizures, often starting in childhood or in the early teen years. This can sometimes result in short-term loss of consciousness or blackouts or convulsions or staring spells. A seizure is usually diagnosed with EEGs, but some kids with autism also have abnormal EEGs, even if they have not had a seizure that an individual can see. Being able to make sure that if a child does have seizures, they are followed by the appropriate neurology services can help to make sure that we minimize damage from those ongoing seizures. There are also several genetic disorders that we know are common with individuals with autism. Fragile X is one of these specific genetic disorders. It is a common form of inherited intellectual disability, and it can cause symptoms similar to autism, but around 1 in 3 children who have Fragile X also meet the criteria for ASD, and 1 in 25 children diagnosed with autism have the mutation that causes Fragile X. So it's definitely a close correlation in the medical diagnostics. There may be other types of genetic disorders that play a role in ASD, and there's lots of studies being done to determine what specific genetic markers might cause an individual to be more susceptible to autism spectrum disorder. Another one that is definitely a large component is gastrointestinal issues. So many parents of kids with autism report frequent GI issues and digestion problems, including stomach pain and diarrhea and constipation and reflux, vomiting, and bloating. Some studies show that individuals with autism are 4 times more likely to suffer from GI issues than the general population. And food allergies can also be really common, as well as oftentimes are individuals with autism, especially when they're really young and maybe don't have as much knowledge or verbal language, have a difficulty explaining when something doesn't feel good inside of their body. And so food allergies and undiagnosed food allergies can be common. There is some evidence for specialized diets to control GI symptoms, but there's no clear evidence in one specific diet that reduces the symptom of autism itself. It may be that behavior improves, partially because as I feel better, my behavior is going to be better. It's not necessarily that removing these things from my diet is causing me to behave better, but that removing these things from my diet is causing me less distress. And when I am less distressed, then my behavior improves. And so the other thing that is a little bit uncertain about individuals with GI issues and autism is that sometimes the picky or restrictive behaviors of individuals with autism may create some of the symptoms of GI concerns, such as poor diet, poor fiber intake, poor fluid intake, or maybe only eating certain foods at certain times. Maybe I only want certain types of things, and so I have a harder time with my GI system because of that, because of my own diet. So that's definitely something to think about in relation to GI issues with individuals. Making sure that an individual on the autism spectrum has a doctor who can really look at the symptomology and talk with families about different things can be really important. I always encourage my families to make sure they talk to their pediatrician or their family doctor before they make any sort of dietary changes to determine if it changes behavior, just so that they are alongside a medical professional when making those choices. Now we're going to move on to talk about mental health difficulties that individuals may also experience alongside their autism. Specifically, I'm going to focus on anxiety, depression, and ADHD. Anxiety is more common in individuals with autism than in neurotypical individuals from a study back in 2008, but there aren't as many current statistics of that. There may be some aspects of anxiety that are different for individuals with autism. Estimated prevalence is that 50% of individuals with ASD will experience some kind of anxiety that impacts their daily life. Some things that might impact anxiety are difficulty recognizing emotions in myself or others, that it's hard to read social situations, and those situations may feel more unpredictable. I may have difficulty identifying when I feel scared or when I feel safe. And so that is definitely one of those things. I may feel constantly bombarded by sensory stimuli, and that may increase my sense of anxiety and a sense of being overwhelmed. I may feel uncertain and not know how to encounter difficulties or how to encounter social situations, and I may be in those situations often throughout my day. I may have performance anxiety or fear of failure, things that make me reluctant to try new things or to go new places because I just don't know what's going to happen. And because individuals with autism often like very predictable patterns and routines, the uncertainty of having to go somewhere new may cause an increase in anxiety. ADHD, when I originally came into the field, we were told that autism and ADHD did not occur together, but now we've had some new research that's really shown that individuals with autism can, in fact, also have ADHD. ADHD is characterized by difficulties with focus, impulsivity, and hyperactivity. And people with ADHD find it challenging to focus on those tasks or following instructions and sit still for extended periods of time. Individuals may also demonstrate creativity or lots of energy or lots of enthusiasm, especially if it's ADHD along with autism. That creativity and that energy and that enthusiasm is part of ADHD. The prevalence of ADHD in individuals with autism is said to be about 30 to 50%. It's based on studies that show that ADHD is most common in individuals with ASD and affects about 1 in 3 kids. So now that we kind of know how to look at the diagnosis of both of those things together, that's an important one to pay attention to. Is this symptom being caused by ADHD, or is this symptom being caused by ADHD or autism? Depression. The Center for Disease Control estimates that depression affects about 26% of people with autism, compared to about 7% in the general population. Some possible reasons for this might include social isolation, social comparison, comparing myself to others because I struggle with the unwritten rules of social behavior. So maybe I'm having a hard time. It appears that everybody else knows those social rules and I do not. Dysregulated emotions in general, so difficulty with being able to regulate my emotions in those social settings. Some common symptoms of depression that you might look for: low mood, weight and appetite changes, sleep disturbances, suicidal ideations, self-injury. Many of these symptoms overlap with those of autism, causing some challenges, right, to determine the diagnosis of depression versus the diagnosis of autism. And because all of these can have some correlation, it can be important to pay attention to the various mental health aspects of ADHD and depression and anxiety to determine, is this individual on the autism spectrum exhibiting these behaviors more than maybe other children on the autism spectrum are? So is it enough to warrant a diagnosis of both? I feel like no discussion around autism and co-occurring diagnoses would be complete without a discussion of sleep. Between 50 and 80% of children on the autism spectrum experience one or more sleep problems. This might be difficulty falling asleep, might be night waking or having difficulty staying asleep, waking too early in the morning, poor sleep quality, even though the quantity is acceptable. Some of the causes of this, GI distress, as we talked about. I may have distress in physical symptoms that I am struggling to explain or to tell somebody about. I may have heightened nervous system arousal. I may have more difficulty being able to just sort of regulate my nervous system because I'm constantly bombarded and overwhelmed by stimuli within the environment. I may have chronic pain or discomfort or undiagnosed chronic pain or discomfort. Because some individuals with autism struggle to communicate those needs, they may have a hard time communicating certain kinds of pain or discomfort, and that might cause sleep disruptions. Sensory sensitivity. There are lots of sensory components of sleep. This might include clothing comfort or sheets or pillowcases or the ways that different scents affect my ability to sleep. I went to a great training several years ago given by an individual on the autism spectrum about the sensory components of sleep. And I had never really thought prior to that how the way my clothes fit with my sheets or the way my pillowcase, if it's soft or what it smells like, how those things might affect my ability to go to sleep. But enough people travel with their very own pillow for me to know that this is definitely something that affects individuals, is that sensory component of sleep disturbance. Also, I might have side effects of my medication. That's something that I think is really important for individuals to think about in relation to sleep. If an individual is on various medications for their diagnoses or for their behavior or for their mood regulation, some of those medications can cause difficulties with sleep regulation as well. And post-traumatic stress disorder and trauma. PTSD is a mental health condition that can happen after experiencing a traumatic event. Symptoms may include re-experiencing the event, having flashbacks, avoiding triggers or things that remind you or are related to that event, negative changes in mood or in thinking processes, or hyper-arousal and overreactivity to things. Research indicates that individuals with autism may be more likely to report symptoms of PTSD, with a probable rate being somewhere between 32 and 45%. It is higher than in the general population. However, in my work as a mental health professional, my experience has been that we tend to sometimes brush aside symptomology of PTSD as being just part of the autism, as opposed to really looking for the possibility that this individual has experienced a traumatic event. In fact, often the risk of PTSD is higher for groups that are exposed more to traumatic events, and research shows that individuals with autism may be at heightened risk for exposure to traumatic events. Because oftentimes, and sometimes that might be because of misdiagnosis, that might be because of social interactions and social isolation, and sometimes trauma can be discounted or missed altogether in our diagnostic picture. It's very important as a mental health professional, I believe, to really ask those questions, to ask the questions of an individual on the spectrum the same way I would ask those questions to any other individual that walked into my office. To ask about traumatic experiences, to ask about bullying or physical and sexual abuse, or even lack of social supports can sometimes be very isolating and can cause trauma symptoms in individuals with autism. Some individuals with autism may experience abandonment or loss of a loved one, or maybe just poor attachment relationships because of that. They may have heightened trauma responses to sensory experiences, fire alarms, automatic toilets flushing, vacuum cleaners, things like that. They may be very sensitive to transitions or to life changes in school routines and changes in teachers and unpredictability in daily life. They may have social difficulties and confusions, so that like misunderstanding of social cues, conflicts with peers, or not even understanding why they're having a conflict with peers. Often our individuals with autism are more susceptible to bullying behavior in their schools and in their classrooms. And so being able to ask about some of those types of experiences can be important and helpful. Also, I believe our families can sometimes experience PTSD symptomology with kids on the autism spectrum because of poor lack of resources or poor lack of connection to other families and other people who understand their experience. And there may be a lack of understanding of psychosis experiences or of the dissociative factors of post-traumatic stress, and we may miss some of those pieces around that. There may also be distress that individuals with autism experience around their own stemming behaviors or social difficulties, and that they feel like they have an undue amount of stress about people being overly nitpicky with their behavior or noticing those kinds of things, or they may be at an increased risk for self-consciousness. So it's important when really looking at individuals with autism to ask those trauma-related questions and ask about those feelings related to social interactions and traumatic experiences that might have occurred for them. In wrapping up, I want to take a moment to talk a little bit about references that I used in creating this PowerPoint on autism and co-occurring diagnoses, but also just to reiterate that a really good mental health assessment and a really good physical assessment can be helpful in both identifying co-occurring diagnoses and in making sure that children and families are receiving the proper care for the difficulties that an individual is facing. I do have some references here for the things that I used to create this PowerPoint. There is the Autism Empowerment website, the National Autistic Society, which has to do with anxiety in autistic people, and my post-traumatic stress disorder in autistic people. That I looked at the Autism Research Institute on co-occurring diagnoses and autism, and that I utilized google.com for images and general definitions around information. I hope this information today has been helpful and that you've learned some things about autism and co-occurring diagnoses that may happen at the same time or alongside of autism. If you have continued questions after this presentation, please feel free to utilize those resources that were listed in the last slide, as well as to reach out to someone from the Kentucky Autism Training Center and the Aetna project that is putting together these trainings to let them know what your questions are and what additional resources and supports that you might need. Again, I hope that today you have learned about co-occurring diagnoses, and I appreciate you choosing to take this learning opportunity today.